Thank you for joining us for the Mentor Program Clinical Pre-Lab on the cervical spine and the upper quarter. With today's presentation, the course objectives are as follows. Participants will be able to identify current literature regarding physical therapy diagnosis and interventions for the cervical spine and upper quarter dysfunction. Participants will be able to utilize diagnostic values for clinical decisions. And participants will be able to identify key biomechanical and anatomical components in the diagnosis and treatment of cervical spine and upper quarter dysfunction. So when we think about the cervical spine or neck pain in general, it's a common ailment that we see in physical therapy with approximately 15% of the patients presenting with neck pain. I would also surmise that a similar percentage of patients with upper extremity dysfunction that are seen by occupational therapists also have cervical spine involvement. When we're looking at treatment, there are three principles that we need to take into consideration. We must look at the best evidence that's available, our gained clinical experience, and what patient values may be present with regards to treatment approaches. As we know, there's often a wide variety of treatment options available for all types of diagnoses that we see in the clinic. And the principles of treatment help establish what treatment approaches we should be utilizing with our patients. One of the ways to help us determine patient perception with regards to satisfaction and functional improvement and pain are to use common outcome measures. Within Benchmark Rehab Partners, we utilize the Neck Disability Index and the Quick Dash for neck and upper extremity dysfunction. We also utilize the Numeric Pain Rating Scale or Visual Analog Scale. With regards to the NDI and the Quick Dash, it's important to understand what the minimal clinical important difference is for each of these tests, as well as any of the tests that we utilize. The NDI is 5 points, the Quick Dash 12%. And just a quick reminder, the minimal clinical important difference is that statistically significant change in a score that the patient perceives as important to them with regards to their functional mobility and dysfunction. Clinical predictor rules are certainly the hot buzzword of the day within our professions. They are algorithmic decision tools designed to aid us in determining diagnosis, prognosis, or a particular response to an intervention. They often take findings from the history, the physical exam, and diagnostic test results. Test item clusters are also diagnostic clinical prediction rules. Some of the familiar clinical prediction rules are the clinical diagnosis of cervical spine radiculopathy, thoracic spine manipulation for cervical spine pain, predicting success with cervical spine radiculopathy, traction for cervical spine pain, as well as others regarding shoulder impingement and thoracic spine intervention. So why do we look at treatment-based classification? Well, for the most part, previous research over the years has primarily looked at patients with back pain or patients with neck pain. And in these two specific regions, we found out that neck pain or back pain are not a particular homogeneous diagnosis. Within each one, there's multiple diagnoses or multiple problems that can occur. So since they were initially looked at as lumped into one group, the results were not very significant. As clinicians, we recognize that there are subgroups within these particular diagnoses, but treatment approaches or classifications have not been identified. But again, we've been able to determine that there are specific signs and symptoms that we recognize in a particular pattern, which can help aid our treatment approach. And that's the basis of what treatment-based classification is. So when we take all of these considerations and look at treatment-based classification, it's also important to the one person that's probably important to the most, and that's to our patients. Because if we can classify our patients correctly, we can administer the most appropriate treatment for them to get them better. So Fritz and Brennan looked at a preliminary examination of a proposed treatment-based classification system for patients receiving physical therapy interventions for neck pain. And the purpose was to describe the proposed classification system. They used standardized method for collecting baseline and intervention data. Outcome variables used included the Neck Disability Index, the Numeric Pain Rating Scale, and the number of visits. Treatment provided to the patient was at the discretion of the therapist. So once the treatment was completed, each patient was classified based on the baseline variables taken. Interventions were then categorized as being matched or not matched, and their overall outcomes were compared. There were 5 classifications that were looked at. They were mobility, centralization, exercise and conditioning, pain control, and headaches. The proposed matched treatments were, for mobility, was thoracic spine and cervical spine mobilization and manipulation and deep flexor strengthening. For centralization, mechanical or manual traction with cervical retraction exercises. For the exercise and conditioning, was upper quarter strengthening and deep flexor strengthening of the neck. For pain control, treatment recommended was cervical spine mobilization and range of motion exercises. And for headaches, was cervical spine mobilization manipulation, strengthening of the upper quarter, and cervical spine deep flexor strengthening. The centralization classification had the largest number of patients, followed by exercise and conditioning, mobility, headache, and pain control. When the data was analyzed, 42% of patients received matched treatments. 59% did not. But the matched interventions showed greater changes in the Neck Disability Index and the pain rating scores. When we look at treatment-based classification, developing these strategies, it's an important priority considering the frequency in which such patients are treated by us. As we noted, it's 15% approximately in physical therapy and probably a similar number in occupational therapy. So we're going to shift gears slightly to pathological barriers of motion, but this relates to all body regions, and in particular the cervical spine and the upper quarter. Whenever we have a patient that presents with a dysfunction, there are 4 major areas that we need to assess and treat. They are muscle, joint, fascia, and compensation. So I'll give an example. A patient presents with shoulder impingement-like symptoms. We go through and we do the examination, and lo and behold, we've done some tests that are highly sensitive or highly specific and determine that the patient truly does have a shoulder impingement. So what do we do next? We may immediately go and start treating the shoulder. Makes perfect sense. That's where their symptoms are. That's where their limitations seem to be. But what might be a better question to ask is, why is that patient having a shoulder impingement? So a further detailed examination may reveal that the levator scapulae on the affected side is extremely hypertonic. So then we need to think, okay, so we've got a hypertonic muscle. Why is that muscle hypertonic? Well, our next step should be as we look at the attachments of where that muscle is. So we then go up to the cervical spine. We look at the cervical spine and we find at C3, C4 that they've got some segmental dysfunction. Maybe they've got a severe hypomobility or stuck facets here, and we feel that that's creating the hypertonicity. So that hypertonicity at the levator scapulae creates an elevation of the scapula that is premature, or when the patient elevates the shoulder, the scapulohumeral rhythm is altered. So then they create an impingement of the supraspinatus or rotator cuff tendon or biceps tendon. And so because of this, they get a painful arc. So right there we have all of our components of the pathological barriers of motion. We've got a muscle hypertonicity due to segmental joint mobility dysfunction that's creating a compensatory pattern. If this occurs long enough, we may notice that they have uh, increased lengthening of muscles in the posterior aspect and shortening or fascial restrictions in the anterior component. So if we haven't gone back and done a thorough assessment for a patient with a shoulder impingement, that we actually found out that they have dysfunctions at the cervical spine that is leading to a chain of events creating a shoulder impingement, we may treat the shoulder and get it 60, 70, 80% better, but we might not be able to get them to that 100% because we didn't look outside the box to determine actually what was causing the problem as opposed to treating the symptoms. In that example I gave, pain presents is our major pain complaint, or is the major complaint of patients, but often that can lie in a different area from where we find the dysfunction. So in the example I gave, the patient presents with shoulder pain, but their actual primary dysfunction is in the cervical spine. And one of the things that we often will see is we'll see a hypo or a hypermobility. So in order to understand that, we need to understand the hypermobility compensation model. So if we have a hypomobility in a given area, this often will cause compensatory hypermobility or hyperactivity in another area. The hypermobile or hyperactive area is typically the area that will be symptomatic. But the hypomobile area is the area that we need to treat as clinicians. Here's just a summary. This table probably will look familiar from perhaps your schooling, but our hypomobile symptoms are typically less painful, less than 5 out of 10. They're kind of deep or dull in nature. There's a stimulation of cartilage typically in the joint that gets a proprioceptive crossover with regards to pain. It's often in a smaller area too. Hypermobile symptoms, typically much higher level of pain, greater than 5 out of 10. It's often sharp in nature. You're often getting tissue damage, which stimulates the nociceptors. And you often get a larger referral area because it stimulates multiple tissues. And since we have multiple tissues, we get a potential of a larger referral area. One other thing as well to consider whenever we're dealing with of course, cervical spine problems, but anything primarily with upper quarter symptoms is we have to look at the cervical spine in order to clear segments to make sure that they're not affecting the function of the upper quarter. So with regards to the shoulder, typically we want to look at C5. If we're having lateral elbow pain or perhaps that lateral epicondylgia, we want to look at our C6 segment. The thumb, C6 as well. Wrist pathology, C7, and the medial elbow, C8 or T1. Again, if we're only treating the areas where the patient is presenting with pain and not evaluating other areas that could be the actual source of the dysfunction, we're not going to get our patients to that highest level of achievement. We often may see our patients specifically for for headache pain, or this may be a secondary pattern or complaint. So since headaches can be quite frequent, it's important to know particular patterns that headaches can take, and that will help you as a clinician determine what areas do I need to go look at to check for dysfunction. The suboccipital headache is probably the most common. If the muscles are irritated, you typically get this pain in the suboccipital region that goes around to the eye. If the actual suboccipital nerve is being impinged, you typically get the back of the skull, the top of the head around to the forehead. Sternocleidomastoid, you typically will see symptoms in the frontal region above the eye, and you can also get ringing in the ears. So if you've got that patient with a headache and tinnitus, your other differential diagnosis may be looking at dizziness or vestibular issues. But also don't forget that if someone is coming in with tinnitus, it could certainly be a dysfunction of the sternocleidomastoid. So again, just differential diagnosis items to look at. Scalenes, typically you get up and around the ear, as well as above the eye for if the posterior scalenes are affected. And so if we remember, the anterior and medial scalenes is to the first rib, posterior scalenes to the second rib. Longus coli, typically longus coli, chronic neck pain, poor posture, kind of that forward head posture, but also surgical candidates that may have had an anterior cervical decompression infusion where their incision is anteriorly. Often the longus coli can become hypertonic or can become scarred down and can definitely limit function with the lack of mobility, but also can cause headaches, and they'll primarily complain of headaches in the eye socket itself. And then, of course, if you have a carrot problem, that can also cause a headache. So moving on to the upper quarter, just a quick review, or a quick reminder, I would say, is that if we're dealing with anything in the upper quarter, we need to address the cervical spine as well. But in particular, we're going to move on to the shoulder. And with regards to the shoulder, the glenohumeral joint will make up for loss of motion from other areas. It's an extremely hypermobile joint, or has the potential to be very hypermobile. So if we've got limitations at the acromioclavicular joint, the sternoclavicular joint, the scapula, ribs, thoracic spine, cervical spine, first rib, your glenohumeral joint will become hypermobile. And if we remember what we talked about earlier, the hypermobile segments or hypermobile tissues are typically the ones that cause the most pain. So again, if we're dealing with a hypermobile type problem, we need to figure out why that area is hypermobile. Capsular pattern is pretty straightforward. When we do look at the shoulder and we're specifically treating the shoulder complex, there should be a treatment order. There should really an assessment order and a treatment order. The first area that we want to look at is the sternoclavicular joint. If the sternoclavicular joint has mobility deficits anteriorly or posteriorly or inferiorly, the subclavius can become hypertonic, which will lock down the sternoclavicular joint. And as we know with shoulder elevation, our clavicle needs to roll, and if the subclavius is hypertonic, that will not allow that to occur. So you can get, again, a chain reaction of events creating a shoulder impingement problem. The acromioclavicular joint, what we're looking at here is primarily external rotation at the acromioclavicular joint, so it will roll posteriorly when you do elevation or external rotation. And as noted there, it accompanies several motions of the shoulder. Scapulothoracic region is one that can often be overlooked, but unbelievably important. It can be affected by multiple things. It can be affected by thoracic dysfunction. It can be affected by rib dysfunction. A combination of the two, if you have a rotated segment of the thoracic spine, can create a posterior rib, say at T5, T6, which will tip the scapula and alter the length tension relationship of the rhomboids and the lower trapezius and serratus anterior, which will affect the scapulohumeral rhythm of the shoulder with elevation. So very important to address areas around the scapula, but also if the scapula is locked down or not moving, again, we talked about how the glenohumeral joint will become hypermobile to address lack of motion in other areas. Next would be the actual glenohumeral joint, and certainly looking at all planes, inferior, posterior are going to be your most common, posterior with internal and external rotation. Once we go through those joints, our next area is to look more globally. Looking at the pelvis and the ilium, primarily for an upslip. Upslip will change on the ipsilateral side, will change the length tension relationship of the thoracodorsal fascia, which wraps around from the lumbar and pelvis through the lats and attaches anteriorly into the clavicle. And so if we've all of a sudden put slack in that system, the capacity for the clavicle and other components of the glenohumeral joint to work correctly is not as efficient, and that can create a impingement. Again, as I mentioned, you also want to look at the thoracic spine, the cervical spine, and the ribs. A couple of key muscles that we make sure that we need to look at. Subscapularis, very significant, often will limit your external rotation, range of motion when when a patient has been in a sling or immobilized for a period of time. If that muscle is hypertonic, it's going to limit external rotation to abduction. Get in there with your hands, release that hypertonicity, or dry needle the area to limit hypertonicity. Pec minor is another major muscle that will affect shoulder mobility. If you're not looking for it, start palpating pec minor, and with your shoulder pathologies, you will find that it is extremely painful. So again, we need to figure out why are we painful. We know its attachments areas to the anterior ribs, 2, 3, 4, and its attachment to the clavicle. The scapula. If that muscle is hypertonic, it's going to create an anterior tipping of the scapula, and so when you elevate, the scapula should move posteriorly and tip posteriorly. That will not occur, and again, that can create some impingement-like symptoms. The trapezius, we're looking at upper and lower components of the muscle. Any dysfunction here alters the forescapula of the scapula. Scalenes, elevated first rib, thoracic outlet. Again, will lock the shoulder up if they are hypertonic, and have produced a elevated first rib. And we talked about the subclavius. If we have that patient that has excessive thoracic kyphosis, we need to address that because the thoracic spine does extend during shoulder elevation. So again, we need to make sure that we're addressing multiple areas whenever we're treating a patient with upper quarter dysfunction. Little tidbit, the lower fibers of the serratus anterior are the ones that assist with upward rotation. Because of the fiber orientation, your serratus punch must be above 90 degrees in order to activate these muscles. Otherwise, we're addressing the middle fibers of the serratus anterior, which are not as active during the upward rotation of the scapula. So once your patient is able to get beyond 90 degrees of elevation without any type of pain or impingement, we need to start addressing the serratus punch, but it needs to be above 90 degrees. A quick look at thoracic outlet. There's 4 major sites. We've talked about scalene hypertonicity, which can create a elevation of the first rib. Pectoralis minor hypertonicity causing compression, and of course poor posture, kind of the anterior inferior shoulder posture. And typically our impingement is more neural versus arterial or vascular. So we want to look at some research. One of the most common things that we often see in clinic is the subacromial impingement syndrome. So Bang and Deal, they looked at a study that was purpose was to compare the effectiveness of 2 physical therapy approaches for subacromial impingement syndrome. Patients presented to the clinic were diagnosed with subacromial impingement syndrome via accepted inclusion criteria in the medical community. They were randomly assigned to 2 groups. One group was an exercise group undergoing supervised flexibility and strengthening, and a manual therapy group. The manual therapy group also performed the same exact exercises in addition to manual therapy. And the manual therapy was conducted to the upper quarter as needed to address any observed impairments. They measured patient perception of shoulder function using a questionnaire, pain response using a visual analog scale, and isometric strength assessment using a stabilized hand dynamometer. The patients were seen for 6 sessions over a 3 to 4 week period. At 2 months post the last treatment, the subjects completed the primary measures again. The results of the study demonstrated that the exercise in the manual therapy group was superior in decreasing pain, increasing strength, and improving function. Pain and strength were statistically significant at 6 weeks, and there were statistically significant changes in functional improvement at 2 months for the manual therapy and exercise group. So moving on, we look at the elbow and the forearm. So we've got multiple diagnoses that we typically will see with this. Probably one of the most common is lateral epicondylgia, which we'll talk a little bit more specifically in just a few minutes. But certainly we can see dysfunction to the supinator or pronator teres. We can see issues to the radial tunnel, of course, medial epicondyle pain, ulnar nerve entrapment. So multiple different types of things that we can see as therapists that we need to address. So when we look at the elbow joint complex, again, we want to look at some specific joints. This particular joint does not have a treatment order that is recommended to follow for the as we talked about with the shoulder. But the 3 areas are the humeral ulnar, the humeral radial, and the proximal radial ulnar joints. With regards to the humeral ulnar, if there's surgery or injury, you can often get scarring of the capsule, which can limit flexion and extension of the joint. So those are things to consider. Humeral radial joint, typically the dysfunction will be compression at the joint. So any type of force translated to the joint in a compression type fashion can create a dysfunction at the joint, often called pushed radius syndrome. The proximal radial ulnar joint, typically our muscles will cause the most dysfunction here. Supinator, pronator teres. Again, if we feel that the muscles are the primary source of dysfunction or their primary source of pain, we need to go back and determine where is that dysfunction. Why is that muscle hypertonic? Why is that muscle painful? So we need to go look at some different areas. So our next study to look at specifically looked at lateral epicondylgia. It was a clinical commentary, and it looked at joint manipulation and mobilization and the management of this diagnosis. The purpose was to describe existing evidence that demonstrated joint manipulation directed at the elbow and wrist, as well as cervical spine and thoracic spine that produced positive outcomes with lateral epicondylgia. There was also a proposed treatment classification system that was introduced and discussed. I primarily looked at 3 treatment areas. They looked at manipulation of the elbow, they looked at manipulation of the wrist, and the cervicothoracic spine. With regards to the elbow, they briefly reviewed Mills manipulation, which is a high velocity thrust to the elbow, creating extension, and preliminary research has shown that's been a very effective treatment approach. They looked more in depth at the Mulligan technique for mobilization with movement for elbow pain, and the preliminary findings demonstrated that it resulted in rapid reduction of pain and improved function. So if we remember, this particular technique, which you'll go over in your lab session, produces a lateral glide while the patient is performing a gripping activity, often with a hand dynamometer. Manipulation at the wrist was also investigated, and they looked at the scaphoid thrust or carpal whip. Preliminary studies demonstrated decreased pain when this treatment approach was introduced versus a multimodal approach of ultrasound, friction massage, and therapeutic exercise. The manipulation of the cervicothoracic spine, studies demonstrated, they looked at multiple studies, and they found that a lot of studies demonstrated both directly and indirectly the prevalence of cervical spine impairments. Gunn and Milbrandt demonstrated that non-thrust manipulation and traction of the cervical spine, as well as isometric neck exercises and modalities, had favorable outcomes. Not super strong evidence, but again, just anecdotal treatment approaches to address at the cervical spine to alleviate lateral epicondylalgia. There was, in this study, 86% of the patients self-reported a good or satisfactory outcome following treatment, which occurred over 5 weeks. They did a 2-month follow-up, and they also found that these this general percentage of improvement persisted at the follow-up. Cleland et al. Looked at 10 patients that were randomly assigned to receive treatment at the elbow or at the elbow and non-thrust manip to the cervicothoracic spine. They attended 10 sessions over 6 weeks. And in this group, or in this study, the results favored the elbow plus the cervical spine group and demonstrated improvements in pain-free grip and DASH scores. They also specifically looked at cervical spine lateral glides with the upper extremity in an upper limb tension or neural tension position. This demonstrated improved neurodynamic mobility, improved pressure pain threshold, and pain-free grip strength. Now, one of the other components that they looked at was a proposed classification system, and it, as described, is basically in its infancy. But they proposed 3 different classifications for lateral epicondylalgia and treatment approaches. The first classification were patients that were likely to respond to peripheral treatment. So that would be to the elbow or the wrist. They exhibited greater affected versus unaffected side-to-side deficits in pain-free grip, and the recommended treatment approach was the Mulligan mobilization limb movement. In the second classification group, these are patients that they felt were likely to respond to the cervical spine lateral glide. They had the patients presenting with greater pressure pain threshold relative to their pain-free grip force. The manipulative treatments to the cervical spine, primarily the lateral glide, would be the treatment of choice. In the third classification system, these are patients that are likely to respond to treatment directed at both the cervical spine and the peripheral joints. They found that there were similar deficits in both the pressure pain threshold and pain-free grip. One of the things that they did say is that in this particular potential classification group, that reassessment regularly was needed to determine if treatment should continue in both areas or just at the cervical spine or just at the elbow. So with regards to the wrist, the 2 primary areas that we're looking at are going to be the distal radial ulnar joint, and we know the ulnar and radius move quite equally together with rotation. The radial carpal joint is also a very important joint that we need to address, not only with wrist pain but also with the elbow pain, as we noted. But here, the radius, the scaphoid, and lunate are in direct contact with the radial carpal joint. So if we've got a dorsally stuck scaphoid, we're going to lose wrist extension. So the wrist extension loss, if the muscles of the forearm are trying to extend the wrist, there's a particular block, but that muscle continues to work excessively to try to improve that wrist extension. That muscle can become hypertonic and painful. We can see damage to the muscle or irritation in the lateral epicondyle area, causing elbow pain. So again, another reason to look down at the wrist if we're seeing elbow pain, to make sure that the scaphoid is moving correctly. If there's an ulnarly stuck lunate, you're going to lose ulnar deviation. If the scaphoid is stuck radially or ulnarly, you're going to lose flexion or extension at the wrist. So again, very important to address the specific carpal bones and to learn the assessment of the joints or the bones of the carpals to make sure that joints are moving correctly, or more importantly, that they're positioned correctly so that they're not preventing motion. So carpal tunnel, Wainer and al. Looked at developing a clinical predictor rule to diagnose carpal tunnel syndrome. They looked at multiple components, but the patients that they assessed were suspected of cervical spine radiculopathy and suspected carpal tunnel syndrome. Both of these diagnoses were confirmed via electrophysiological lab test results. All subjects underwent a standardized exam. They had a specific history exam that consisted of 9 questions. They underwent a conventional neurological exam. There was a wrist ratio index that was performed, as well as provocative tests, which a few are listed here on your slide. After the data was analyzed, they found that 5 variables predicted carpal tunnel syndrome. One was a particular question, which was shaking of the hands for symptom relief. Another one was the wrist ratio greater than 0.67, and so in order to determine the wrist ratio, you utilize calipers at the wrist crease, looking at the anterior posterior measure and the medial lateral measure, and then you divide the AP by the ml to get your wrist ratio. A symptom severity score of greater than 1.9, diminished sensation in the median nerve sensory field, and an age greater than 45 years old. So when all the data was crunched, if you have 4 or more positives, you have a likelihood ratio of 4.6. If all 5 tests are positive, you have a likelihood ratio of 18.3. So 79 subjects completed the testing. The carpal tunnel prevalence based on the clinical predictor rule was 34%, or 28 subjects. The patients with radiculopathy was 19 subjects, and 32, or 23%, and there's 32 that did not differ between cervical or carpal tunnel. They did find that the clinical predictor rule was more useful in the diagnosis of carpal tunnel syndrome than any other single test item, and resulted in post-test probability changes up to 56%. So we've covered a lot in this brief little talk on the cervical spine and the upper quarter, and by no means is this the end-all be-all of evidence and treatment approaches, but we feel that it gives you a good basis of where to begin to look at or to expand areas that you're already looking into. We need to utilize the evidence that's available. If there's classifications that are available, we need to try and utilize those as possible, because we found specifically with the cervical spine that if we can match our treatment approaches with the classification, our patients will have better outcomes. Don't treat with your blinders on. The patient comes in with shoulder pain or elbow pain. Make sure that you're assessing, seriously. They always tell you this in school, look above and below. But you've got to look above and below to find why is the patient having the pain that they're having or having the dysfunction that they're having, so that we assess all those areas and address all the possible areas so that we can get our patients to 100% success rate. Thank you for your time.